The case that I mentioned this morning, Wyatt versus Stickney, where we started, Judge Johnson began that case, and over about 20 years, Judge Thompson finished it. And Judge Thompson wrote in the consent order that after the governor had promised that they would make sure that the legislature appropriated appropriate money for community mental health. At the close of his order, he said, and if they don't, as surely as night follows day, they will return to this court. And they have. In the 300-page opinion, Judge Thompson has laid out page after page after page of breadcrumbs to follow along to reach a comprehensive community mental health system. It is just dramatic to read that because he's laid out the mosaic of what we've talked about today, a community mental health continuum in the prison system. And now there's the fight going on about how much money will be spent, how they will do it, whether it will be done appropriately based upon the liability that he's already found. And that kind of mosaic is what we need to follow into the community mental health system. I'm very hopeful about the money they talked about today. But you'll recall the letter we sent last year asked for an additional $98 million. There's some coming. We didn't expect it all to be there at one time, but we've got to build and build. And with the really miraculous work that the department is doing, people like Kim, you sit down with her in the department and she starts talking and you get excited too because she's so excited about where we're going. And then she ropes you into her committee work as well. But it's very important to understand where those cases came and where they're going, because if it doesn't get done, as surely as night follows day, this will have to be settled by litigation. And with the people in this room and the people that we know and the people that they know, there's no reason to have to return to litigation. We can figure this out. Every politician in the state should have to listen to Judge Leifman's presentation and see how easily it can be done. Now, that was a big fight. There was a lot of work into it, and we're going to make sure that people do that work. But it's critical that we do those sorts of things, because otherwise we're leaving our constituency to fend for themselves, and we know that's not possible. I'm going to let Jackie talk about the medical part for a little bit, and then we'll kind of back and forth.
I'm really happy that Judge Leifman texted me and said to show that, because I think that's an incredibly powerful video. We do have the slides. Go to the next slide, please. Great. So the time is now. I just want to remind people about some of the general themes that we covered today. I understand I'm preaching to the choir, that those living with mental illness have a physical illness in their brain. It's not voodoo. It's not magic. Something is wrong with the brain. Now, wrong doesn't mean bad, but something's wrong. Something's upset in the brain, and we need to address it like a medical illness. So they need and deserve treatment, not delay and not incarceration. Sometimes people who are living with mental illness lack insight. They don't believe they have an illness, and I'm telling you, it's incredibly difficult to try and talk someone into taking medication or receiving any other kind of treatment if they don't believe they have an illness. And so that's one of the struggles that we have within the system. But without treatment and without support, crisis happens. And we've talked today and we've seen today about if crisis happens, there are different ways to respond to it. And we heard a very compelling lived experience this morning about what happens when we don't respond to a crisis in the best way. Next slide. So we need to think about how should we approach treatment. And this is from my point of view as a treatment provider. But it's also from the point of view of a family member. I have 3 very close family members who have serious mental illness and have struggled with it, and thank God they are on a great recovery trajectory. But I've seen how they have struggled with their illness and how they have been engaged or not engaged in their treatment considerations. Certainly, early identification is important, prevention is important, but we haven't really commented or we've kind of skirted the issue of relationship and engagement. Because if you think about it, working in collaboration and sharing a decision-making process is a whole lot better than forcing somebody to take medicine. When I worked with patients at the mental health center, I was incredibly fortunate to be there for 27 years, so I knew my patients. We were talking about sharing personal stories with patients. I had patients who asked after the baby. Well, my baby's now 24 years old, but many of them were with me when I was pregnant with Sarah. So they knew of her, and I would bring my kids to the day treatment parties, and so there has to be some flexibility of that boundary, I think, to start the engagement process. But I would set my pen down and say, how are you doing? Because my nurses had gone through the checklist, and were they suicidal, were they hearing voices, seeing visions? Those are all important things, but how you doing? Well, I'm doing okay. Well, how's your medication doing? Well, I said, what's the matter? I go, well, doc, it affects my nature. Which, I give talks to people up north, and they're like, what are you talking about? Nature, obviously, is sexual functioning, and it's a nice way to say it. It affects my nature. And how many of y'all would take a medicine that affects your nature for the rest of your life? No hands. Is it hard to expect that my patient would feel the same way? How do I engage somebody in taking medication that affects their nature? It's a shared decision-making process. What is it that you want? What's worked in the past? What do you think will work? Do we need to change things around? Now, I don't write for heroin, but I will listen to people and say, what has worked for you? I also don't write for a lot of benzodiazepines, but we negotiate, and it's a shared decision-making process, so it's a shared responsibility. If my doctor says, well, what do you think is going to help with your asthma? And I'm living with asthma, and I'm on theophylline, which is like the oldest medication in the world. And she's like, no, let's put you on this, let's put you on that. I said, it works. Why would we change it? If it ain't broke, don't fix it. And so you have to engage the people that you want to treat. Adherence is better than compliance. Compliance means I'll do it because you told me to do it. Adherence means I'm choosing to do this because I think this is the right path. And if you can step into that relationship and that engagement with consumers, that's a better path. And partnership is better than a hierarchy. Now, I did have many patients that I'd say, well, what do you want? And they'd say, doc, whatever you say. Okay, and those are kind of old-timey patients. But I think the relationship, if it's not a hierarchy, but it's a partnership, works a whole lot better. Next slide, please. We've heard a plethora of evidence-based practice about how community supports are imperative. And Kim, where's Kim? That was just a fantastic, fantastic report on housing and the efficacy of housing and a thoughtful approach to how we're going to strategize about getting more housing, because community supports are imperative. Housing is treatment. We need to understand mental health affects it's not just neurotransmitters that are broken. I have residents who say, well, I'm just going to change his medicine and that's it. And I said, well, what about having a relationship with this person? I would always ask 2 questions at the end of every intake interview. I'd say, what have we not asked you that we should know about? And where do you want to be in 5 years, and how can we help you get there? Because as I said this morning, kind of what we may think is important isn't the most important thing in the person's life. things do get affected by mental health or mental illness: cognition, behavior, perception. So you need to have a treatment team, including the physician, including peer specialists, medication, cognitive rehabilitation, and therapy. We didn't really touch on those today, but those are incredibly important treatment options so we can help people kind of get back to where they are. I had one young man that I treated with clozapine when he was about 36. He had been sick since he was 18. And it is as if I had flipped on the light switch, and his affect brightened and his thinking got organized, and he came to me horribly depressed because he said, I just lost 18 years of my life. They're gone. What am I going to do? And so we have to have things in place to help people catch up from what they've lost. And we need to make sure that they have a capacity to live a full life. And we've talked about a lot of those things today. Case management, stable housing, transportation. People need to be able to eat. I had a person come in and say, oh, I'm not doing too well. I said, well, what's the matter? Well, I haven't eaten in 2 days. Well, I challenge any of us to not eat for 2 days and be able to think straight. I mean, we have to be thoughtful about that granular of an issue. They need to be able to work if they can work, and financial stability. The last slide. So we need to collaborate, have a collaborative process. That was so wonderful to hear Kim kind of review the planning and strategic planning process that occurred, getting everybody involved. And that's why it's wonderful that you all are here, that we had legislators here, that we had county commissioners here. We all have to do it. Change can happen, but we all have to do it. We need to stop pointing our fingers. I can only underscore what everybody has said today, including peer specialists, that services need to be patient-centered and strengths-based. When I ask my patients or my residents to present a patient, they'll go, well, he hears voices, he's using drugs, he's homeless. And I said, yeah, but what strengths does he have? I mean, what can we capitalize on? They look at me blankly, and I'm like, well, do they have a supportive, involved family? Are they trying to get sober? Is their physical health good? Do they have a sense of humor? Are they working on their GED? All those kind of things helps you rethink and humanize the people with which we work. We need to be creative in our service provision. The housing thing is so cool. Urgent care versus the emergency room, telemedicine we talked about earlier, and the use of peer specialists. And again, we need to bust stigma. I think this meeting was a good way to do it. The video that Judge Leifman shared with us really underscored just shining the light on the inhumanity of the situation in the 9th floor of that jail was enough to help change an entire system of care. So they did it there, and I think that we can do it here. Thank you.
I want to reiterate what Jackie said about not pointing fingers. I mentioned that this morning. We can't point fingers. Pogo said it. I know some of you don't know who Pogo was. But Pogo was a comic, and Pogo's greatest philosophy was, we've met the enemy and he is us. And that says it all. We all have to work together. We've got to communicate. If X county wants to do something in a hospital in Y county, somebody has to be talking about X county's payments for these sorts of things. Same thing with communities. It's a community effort, and we've all got to work together. Legally speaking, there are statutes and there are cases decided by judges. The legislature builds a structure with laws, and then the court carries that out. And what the legislature has done in Alabama is a basic structure for how to put out a fire. If you're in crisis, this is how you be in the hospital. These are the standards under which you can stay there. And if you don't meet those standards, you got to go out. Nothing about prevention, nothing about treatment, nothing about anything. The Supreme Court decided in Olmstead that treatment must take place in the least restrictive manner as close as possible to the community. The Wyatt versus Stickney case that Judge Johnson and Judge Thompson put together talks about de-warehousing people and putting them in their local community and treating them appropriately. That's what we have to do. A concentration of where the statues have been is putting out fires. Nobody here today talked about putting out fires except that that's not what we want to do. If we do the things at the beginning, if we provide treatment in the local community, if we make sure there's a roof over their head, if we make sure there's meaningful work is like medicine. My son is so proud of what he can do with his work. And I know a lot of the people that he works for and the compliments that he gets. That means everything going home at the end of the day. We've got to find ways for those who can work to work. We've got to find roofs. We've got to find medication available. I remember when he was at Children's Hospital and the insurance company, I think one of Jackie's favorite people, sent him home the first day from Children's. And his doctor, Tommy Vaughn, said, I said, well, is he ready to go home? And he said, no. And I said, well, I'll pay for it myself. And he said, well, you can't afford it. And I said, well, how much is it? He said, $10,000 a day. Well, you're right, Tommy. He said, take him home, bring him back tomorrow, we'll get him in. And I faxed off a letter when I got him back in the hospital to Champas and said, I know you have derivative immunity and I can't do anything to you, but I do know where you are. And if he doesn't stay there till the doctor says he can go home, I'm coming to find you. Probably didn't have any back, but he stayed there. It's community involvement. We've got to work within the structure we have. We got to love what we're doing, have passion about it, work together. The law can be our friend. It can be our enemy. The doctors can be our friend. I know some who can be our enemy too, as Jackie nods her head. But what today has shown me that there's an excitement that we can translate. For those of you on the coalition, you'll be getting an email tomorrow. We'll have a conference call next week. We're going to have some follow-up to this for those who didn't attend to make sure they get the benefit. Talk to your friends. Talk to your neighbors. This is important stuff. And we need to continue that. This isn't one day. This is one day out of the rest of our opportunity for as long as we're breathing. And as long as I'm breathing, I'll be here. Thank you very much for coming today, and we appreciate your effort. Oh, come on up. One last thing. Would you introduce yourself?
Yes, sir.
And then I'll tell them what it's about.
All right. I'm Hal Taylor, Secretary of the Alabama Law Enforcement Agency. You hold that or put that?
Yeah, just hold it.
I'll hold it. Thank you.
As I told you earlier, we got a seat with APOS to help put together the curriculum for the academy for CIT, and then it's beneficial then to get out into the field and come back. And so now that we've got such a demand for CIT, we just really can't even fill the seats yet. And so the field is demanding certain things like that as well. And I just wanted to give him an opportunity to say a couple of things about the law enforcement aspect of this, because without them, there's a lot of stuff we can't do. And if they're trained properly, we got a great system.
Thank you. Thank you very much. And thank you for this opportunity to come today. Thank you, Commissioner Bashir. The reason I'm here, we were talking one day, and Lynn says, how do you train your troopers? Are they trained in mental awareness to spot things and do things? And I said, yes, ma'am, but I bet we could do better. And we are. So we started doing better, and we're training more. APOST has it in there now in their curriculum, so we'll adopt it in ours, in our yearly annual CEUs that we do. We have to have 12 a year, and we'll adopt that and do that and start doing more. What that brought to my attention as we've talked, though, is what can we do? And we can do a lot more. You know, we trained our SWAT teams, our hostage negotiators, barricaded subjects and things like that to learn things when they're talking to them. If they do have a cell phone, they do have communications, you know, things that they can learn. Are they off their medicine? A lot of times when we get there, they have, as you said, haven't eaten in 2 days and haven't taken medicine. And they were supposed to, and somebody was supposed to check on them, and they didn't check on them. The next person that checks on them is us. And when we get there, then we are dealing with just what you said. Somebody who hasn't eaten, I can't think straight if I don't eat in 3 or 4 hours of each other. So 2 days and no medicine. So that's what we're teaching and training our officers, and that's what APOS will do with the basic academy as well, to recognize those signs and know that person is not wanting to harm them. It's a matter of life or death. I mean, somebody comes out of the house with a gun in their hand, and as a police officer, I mean, that's a threat. Drop the gun, drop the gun. So they might not even know what they're doing. They may have no idea. This person who hadn't eaten in 2 days or hadn't taken their medicine has no idea what they're doing. So we're training. We're doing more through the state police, through the troopers, SBI, through all of my people at the state level, to recognize these things and be more prepared. And I thank you because you brought that to our attention, and we're doing more. And I think it will only help, especially with the basic people coming out as they come up, and us collaborating and working together. Thank you very much.
And we're here too. Any way we can help, we're going to help. All right, don't forget to fill out your evaluations. Those are important for your credits. You want them at the desk out front? Yeah, just drop them at the desk out front. Thank you very much for coming. Don't forget, this is day one. We got a lot of work to do. Safe travel home. Thank you for coming.